Hello everyone, today I'll be discussing about systemic lupus erythematosus. Systemic is nothing but affecting multiple organs. Lupus is a disease affecting skin. Erythematosus is reddening of the skin. SLE is a chronic multi-system disorder commonly affecting women during their reproductive years. Here, there is an injury to the body's own cells leading to damaged cell proteins and DNA. Injury to the group of cells can subsequently lead to organ injury. SLE has these following characteristics: protean manifestation and variable behavior, remission and relapses, multi-system involvement mainly affects skin, kidneys, joints, serous membranes and heart, broad spectrum of autoantibodies. Most important is anti-nuclear antibodies. The objectives are pathogenesis of the SLE, diagnosis in relation to criteria for SLE. SLE is an autoimmune disease involving multiple organs characterized by a vast array of autoantibodies, particularly anti-nuclear antibodies, in which injury is caused mainly by the deposition of immune complexes and binding of antibodies to the various cells and tissues. Injury to the skin, joints, kidneys, and serous membrane is prominent, but any organ in the body may be affected in SLE. So, SLE predominantly affects women with a frequency of 1 in 700 among women of childbearing age and female to male ratio of 9:1 in the reproductive age group of 17 to 55 years. The hallmark of SLE is production of autoantibodies, several of which like antibodies to double-stranded DNA and so-called Smith antigen are virtually diagnostic. So let's discuss about the etiology of the SLE. SLE is an autoimmune disease in which the fundamental defect is failure of self-tolerance. It leads to production of many autoantibodies that damage the tissue either directly or indirectly by depositing immune complex deposits. A combination of genetic, environmental, and immunological factors play a role in pathogenesis of SLE. Let's discuss about genetic factors. There is familial predisposition. First degree relatives have increased risk. Up to 20% of the clinically unaffected relatives show autoantibodies or immune abnormalities, and there is high rate of concordance, like more than 20% in monozygotic twins than in dizygotic twins. And specific alleles of the HLA-DQ locus have been linked to production of anti-DS DNA, anti-Smith and anti-phospholipid antibodies. Deficiency of early complement components like C1q, C2, C4 leads to the impaired clearance of immune complexes and apoptotic cells and promotes loss of self-tolerance. Immunologic factors. There are type 1 interferons, toll-like receptor signals which play important role here. There is failure to self-tolerance, failure to eliminate self-reactive B cells in the bone marrow, and there is CD4 helper T cells activation. CD4 plus helper T cells specific for nucleosomal antigens. These escape tolerance and produce high affinity pathogenic autoantibodies. And toll-like receptor signals like TLRs present in the B lymphocytes normally sense microbial products including nucleic acids. In SLE, nuclear DNA, RNA within the immune complexes may activate B lymphocytes by engaging with TLRs, and these activated B cells specific for nuclear antigens may produce anti-nuclear antibodies. And there is persistence of autoreactive lymphocytes results in chronic immune activation. Environmental factors. UV radiation, cigarette smoking, sex hormones, drugs are the main environmental factors which are responsible for SLE. UV light exposure induces apoptosis of the cells due to increased nuclear antigen release and enhances TLR recognition of the material. Cytokine induction by UV light produces interleukin 1, promoting inflammation. And sex hormones. SLE is like 10 times greater during the reproductive period in women than in men. The gender bias of SLE is attributable to the actions of sex hormones and partly related to unknown genes on X chromosome, independent of hormone effects. Drugs such as hydralazine, procainamide, D-penicillamine, and isoniazid can induce SLE-like response in humans, and also cigarette smoking. It is associated with development of SLE. Let's discuss about the pathogenesis of the SLE. It is clear from this discussion that the immunologic abnormalities in SLE, like both documented and postulated, are varied and complex. Nevertheless, an attempt can be made to synthesize results from patients and animal studies into a model of pathogenesis of SLE. So, if I have to tell about the main steps in SLE, they would be increased apoptosis and impaired clearance of the apoptotic bodies, leading to accumulation of the increased amount of nuclear antigens, which leads to the production of anti-nuclear antibodies, and there is further formation of antigen antibody complexes in the circulation, and the endocytosis of the immune complexes by the B cells and the dendritic cells, and there is stimulation of B cells and T cells, and finally leading to persistent production of IgG autoantibodies. So let's discuss the pathogenesis of the SLE with the help of the diagram. On the right side you can see external triggers like UV radiation and other environmental agents may cause death of the cell by apoptosis. And inadequate clearance of these apoptotic bodies results in accumulation of large amount of nuclear antigens. It is partly due to defect in the complement proteins. On the left side you will see the susceptibility genes with the failure of self-tolerance. Genetic abnormality in B and T lymphocyte is responsible for the failure of self-tolerance. Stimulation of self-reactive B cells. It produces antibodies against the self-nuclear antigens. And further, there is formation of antigen-antibody immune complexes in the circulation. And there is endocytosis of the immune complexes. The antibody portion of the immune complex bind to Fc receptors on the B cells and dendritic cells, and immune complexes may be internalized by endocytosis. TLR engagement by nuclear antigens. Nucleic acid components of the immune complexes binds to TLRs of B cells and DCs. TLR stimulates B cells and DCs. So binding to TLR stimulates BCs to produce autoantibodies, activate dendritic cells to produce IFN alpha, which stimulate B and T cells to further amplify the immune response and cause more apoptosis. And finally, there is persistent production of autoantibodies. Thus, a cycle of antigen release and immune activation results in the persistent production of IgG autoantibodies. So next is mechanism of tissue injury. Autoantibodies mediate tissue injury. The first one is immune complex mediated injury or type 3 hypersensitivity. Deposition of immune complexes in kidneys, blood vessels, skin and joint lead to complement activation followed by inflammation. It is the most common cause of tissue injury and visceral lesions. The second one is antibody mediated cytotoxicity, that is type 2 hypersensitivity. Autoantibodies against RBCs cause hemolytic anemia against WBCs causes leukopenia and platelets cause thrombocytopenia. Autoantibodies against self-surface antigens specific for RBCs, white cells and platelets opsonize these cells, promote their phagocytosis and lysis, leading to cytopenias. The last one is antiphospholipid antibody syndrome. Patients with antiphospholipid antibodies are prone to venous and arterial thrombosis. Next is diagnosis in relation to criteria for SLE. Classification criteria used in SLE are ACR criteria, American College of Rheumatology, and 2019 EULAR ACR classification criteria. European League Against Rheumatism, American College of Rheumatology. There are two kind of criteria that are used for the classification of SLE. They are clinical criteria and also immunologic criteria. In clinical criteria, we have 11 criteria. Presence of any 4 or more criteria of the 11 is diagnostic of SLE. They are malar rash, discoid rash, photosensitivity, oral ulcers, arthritis, serositis, renal disorder, neurologic disorder, hematologic disorder, immunologic disorder, and anti-nuclear antibody. The first one is acute cutaneous lupus, malar rash, fixed erythema, flat or raised over the malar eminences, tending to spare the nasolabial folds, and there is also photosensitivity. Here you can see the malar rash kind of looks like a butterfly rash. It is a typical presentation of the SLE, butterfly rash over the face, fever, pain, without deformity in one or more peripheral joints, pleuritic chest pain, and photosensitivity. The second one is chronic cutaneous lupus, that is discoid rash, erythematous, raised patches with adherent keratotic scaling and follicular plugging. The third one is non-scarring alopecia. Alopecia is nothing but hair loss, that is like diffuse thinning or hair fragility in the absence of other causes. The next one is oral or nasal ulcers. Oral or nasopharyngeal ulceration, they are usually painless, observed by physicians. Joint disease or arthritis. Non-erosive synovitis involving 2 or more peripheral joints, characterized by tenderness, swelling, or effusion. Next is serositis, pleuritis, pleuritic pain or rub or evidence of pleural effusion, and also pericarditis. Then there is renal disorder, there is persistent proteinuria or red cell casts. Neurologic disorder, there are seizures, psychosis, myelitis or neuropathy in the absence of offending drugs or other known causes. There is hemolytic anemia, leukopenia or lymphopenia, and thrombocytopenia. If we talk about immunologic criteria, there are anti-nuclear antibodies, anti-dsDNA antibody, anti-Smith antibody, antiphospholipid antibody, low complement, direct Coombs test. Anti-nuclear antibody, that is abnormal titer of anti-nuclear antibody by immunofluorescence, anti-dsDNA antibody, anti-Smith antibody, presence of antibody to the Smith nuclear antigen, antiphospholipid antibody, positive finding of antiphospholipid antibodies based on abnormal serum level of IgG or IgM, anticardiolipin antibodies, positive test for lupus anticoagulant using the standard test, false positive serologic test for syphilis known to be positive for at least 6 months and confirmed by negative Treponema pallidum immobilization or fluorescent treponemal antibody absorption test. and there are low levels of C3, C4 or CH50. Direct Coombs test is like an assay for anti-red cell antibody in the absence of clinically evident hemolytic anemia. So let's look into the autoantibodies in the SLE. SLE is characterized by the production of several diverse autoantibodies. Some antibodies are against different nuclear and cytoplasmic components of the cell that are not organ specific. Other antibodies are directed against specific cell surface antigens of the blood cells. If I have to tell about the importance of autoantibodies, they are used in diagnosis and management of the patients with SLE, and they are also responsible for the pathogenesis of the tissue damage. And then the types of antibodies are anti-nuclear antibodies, autoantibodies against blood cells, namely red cells, platelets, neutrophils and lymphocytes. Antiphospholipid antibodies are detected in 50%, 40 to 50% of the SLE patients, but they are not specific for SLE. Antibodies react with plasma proteins of the complexes rather than directly with the phospholipids. Antiphospholipid antibody includes lupus anticoagulant antibody, anticardiolipin antibody and anti-beta-2-glycoprotein antibody. Complications, they lead to increased venous return and arterial thrombosis and thrombocytopenia, which lead to recurrent spontaneous miscarriages and focal cerebral or ocular ischemia. Antibodies against phospholipid beta-2 glycoprotein complex also bind to cardiolipin antigen. Since cardiolipin antigen is used in serological tests for syphilis, SLE patients may give false positive serological reactions for syphilis. There are two tests that measure different antibodies, anticardiolipin and lupus anticoagulant. They are ELISA for anticardiolipin, and the second one is a sensitive phospholipid based activated prothrombin time, such as the dilute Russell Viper venom test. If you guys look at these pictures, these are the classical ANA immunofluorescence images. On the left side, we can see the different nuclear staining patterns observed in ANA testing, that is anti-nuclear antibody testing. Speckled pattern shows granular staining of the nucleus, and it is due to antibodies against extractable nuclear antigens such as methane, etc. This is frequently seen in SLE. Homogeneous pattern shows uniform staining of the entire nucleus and is caused by antibodies against double-stranded DNA and histones. This is commonly seen in SLE. Nucleolar and centromere patterns are less commonly seen in SLE. Peripheral pattern or the rim pattern shows intense staining at the nuclear periphery and is associated with anti-double-stranded DNA antibodies, which strongly suggest active SLE, especially like lupus nephritis. So the staining pattern provides an important clue to the type of autoantibodies present and the underlying autoimmune disease. On the right side, this image shows actual HEP2 cells under fluorescence microscope after incubation with patient's serum. The bright green fluorescence of the nuclei indicates the presence of anti-nuclear antibodies in the patient's serum. In SLE, ANA positivity is seen in more than 95% of the patients, so it is highly sensitive screening test. However, because ANA is not so specific, further antibody testing such as anti-dsDNA anti-Smith antibodies is required for confirmation. Laboratory diagnosis of SLE. The purpose is to establish or rule out the diagnosis, to follow the course of the disease, and to identify adverse effects of therapies. Tests for autoantibodies. ANAs are found in almost all patients, but it is not specific. Various methods of detecting antibodies include indirect immunofluorescence assay. They can identify ANAs. Significance of the indirect immunofluorescence assay are they are extremely sensitive, like positive in more than 95%, but the con is limited specificity because it is positive in patients with other immune diseases, chronic infections, and cancer. The next test is multiplex flow cytometry immunoassay and ELISA for Smith antigens. Standard tests for diagnosis include complete blood count, platelet count, ESR which is raised, and urine analysis. Tests for the following disease course. These tests indicate the status of organ involvement known to be present during SLE flares. Renal involvement. Urinalysis may show hematuria, red cell casts, proteinuria, or nephrotic syndrome. Hematologic changes. Hemoglobin levels, anemia or platelet counts, thrombocytopenia, and ESR. Serum levels of creatinine or albumin. Decreased complement component levels in serum such as C3, C4 are often indicators of enhanced consumption and increased disease activity. The course, it is like variable and unpredictable. It shows remissions and exacerbation. With this, I'll move on to the clinical features of the SLE. SLE is a multi-system disease with variable clinical presentation. It usually occurs in young women between 20 to 30 years but may manifest at any age. It predominantly affects women with female to male ratio of 9:1. It may be acute or insidious with fever in onset. The typical presentation is butterfly rash over the face, fever, pain without deformity in one or more peripheral joints, pleuritic chest pain, and photosensitivity. SLE patients are susceptible to infections because of immune dysfunction and treatment with immunosuppressive drugs. Clinical features are serositis, oral ulcers, arthritis, photosensitivity, blood disorders like anemia, leukopenia, renal disorders, and ANA positive immunologic, that is anti-dsDNA, anti-Smith antigens are present, and neurologic, they are seizures, psychosis, etc. Here you can see Libman-Sachs endocarditis on the left side and wire loop lesions on the right side. These are the manifestations of the immune complex mediated injury in SLE affecting heart and kidney respectively. Libman-Sachs endocarditis, it is a form of non-bacterial endocarditis seen in SLE. There are multiple small sterile vegetations on both sides of the valve leaflets. Usually mitral valve is affected more. The vegetations are irregular, granular, and firmly attached. On the right side, you will see the wire loop lesions, that is in lupus nephritis. Here the capillary walls appear thick, rigid, and eosinophilic. They resemble loops of wire under light microscope. Alright then, before ending this discussion, I would like to summarize SLE in few points. SLE is a complex disorder of multifactorial origin which results from interactions of genetic, immunologic, and environmental factors. SLE is a disease caused by autoantibodies against numerous self-antigens and forms immune complexes. Etiological factors responsible for SLE can be genetic factors, environmental factors, immunologic abnormalities. SLE shows features of both type 2 and type 3 hypersensitivity reactions, and important is Liebman-Sachs endocarditis is seen in SLE, and wire loop lesions seen in diffuse proliferative glomerulonephritis in SLE, and antibodies specific for SLE are double-stranded DNA, spliceosome proteins, Smith antigen. So serum ANA is a screening test for SLE, not a confirmatory test. Yes, that is it. Thank you everyone.